what the world hopes to do. So we talk about this thing about the Cascade of Care. Everybody's talking about this now. And what that means is, of all the people who have HIV, how many know about it? And if they know about it, how many of them have gotten to be in care? And of those in care, how many are on treatment? And of those on treatment, how many have a suppressed viral load? So UNAIDS tells us that by 2020, which is not that far away, 90% of people with HIV are going to know, 90% are going to be on treatment, and 90% are going to have an undetectable viral load. Wow. We got a ways to go. So where are we right now? 37 million people know they have HIV. Half know it. Of those, most, 40% are in care. And of the ones in care, 32% are undetectable. We got a ways to go. So these doctors says, well, how can we get people to be better at following their disease and going to the doctor and having their tests done? So what they did is they bribed them. So if you did your blood test, you got $25. And if you came to the doctor, you got $100. So what do you think happened? Everybody came and got their money, but they didn't take their pills. Anyway, it was a good try. All right. Lipodystrophy is a topic that's kind of gone away. Hey, we don't hear people talking about that too much. And does it still exist? So what we meant by lipodystrophy is some people lost fat. So they lost fat from their face, they lost fat from their butt, they lost fat from their arms and legs. And some people gain fat, so they gain fat around the belly and they gain fat around the back of the neck. And we used to link that to some of the old drugs we used. So we used to link the loss of fat to AZT and D4T. We used to link the body fat to the protease inhibitors. But, despite it, we never ever really knew why. We didn't really understand why. And so everybody's saying, well, we don't use all those drugs anymore. Is lipodystrophy still there? Is it not there? Or is it just slow, and with the new drugs, we may not see it for a while? So this was a study that was done, the one I talked to you about earlier, where people got atazanavir in blue, the raltegravir in red, or the darunavir in green. And this is what happened to their fat over time. And this is the change in fat. And now it looks like on the new drugs, people aren't getting lipodystrophy, just everybody's getting fat. Doesn't look like we're seeing lipodystrophy with the new drugs, but again, it's a little too early for us to know. People with HIV are aging, and we're starting to worry, are we going to see more cancer as people age with HIV? And even though the virus might be under control and the T count might go up, the concern is the T cells might not work perfectly well. And does that put somebody in an environment where cancer might be higher? And so this was, again, a study in the United States looking at people with HIV more than 65 years of age to say what cancers are more common than in the general population. And the biggest one was Kaposi sarcoma, so even though we don't see it as much anymore, it's clearly way more common in people living with HIV. The next highest ones on the list were these lymphomas, or these cancers of lymph glands. They are higher than in the general population. And the other major one was anal cancer, particularly in gay men. Lung cancer so far is not any higher in people living with HIV than in the general population, but we're worried because more people with HIV smoke, and as more people are going to live longer with HIV, we're worried that that one may become a problem. Colon cancer, so far, not any higher. So the routine colonoscopy, after you hit 50, you have that every 5 years. Doesn't look like we have to do it any more often because you have HIV. For women, breast cancer does not appear to be any higher than the general population. So again, the mammography, just routine, we don't need to change it. And again, for men, prostate cancer does not so far appear to be higher. So when you get 50 or 60, you got to have the routine stuff like everybody else in the population. But it doesn't look so far that we need to do anything special. But obviously we need to keep watching this over time. And so this was, if you are going to get cancer, what's your biggest risk factor? Smoking. If I can't convince you with this graph, I'm never going to convince you, but having hepatitis B, having hepatitis C, having a low T count, having a high viral load, having had AIDS in the past, no, smoking. So if you can do anything healthy for yourself, quit smoking. So the other big news in HIV care is managing hepatitis C. In Toronto, about 10% of people who have HIV also have hepatitis C. In Vancouver, it's closer to 20%. In Montreal, it's about 15%. In Saskatchewan, it's about 50%. So everybody should have been tested for hepatitis C, and if you haven't, get it done. Why? Because we got some great new drugs. So in the past, the drugs that we had were horrible. They made everybody sick. They only worked a third of the time. And we generally didn't use them because they were so horrible. We have a whole bunch of new drugs now that work like a charm. They work in 12 weeks. They cure 98% of people, cure from their hepatitis C, and they have hardly any side effects. So you're saying, what's the downside? $100,000 of treatment. So the last thing I want to talk about is the whole concept of prevention. So we call this PrEP and PEP. Of course, everything has an acronym. PrEP, pre-exposure prophylaxis. PEP, post-exposure prophylaxis. So the whole idea around this is somebody who is HIV negative, who is potentially going to be exposed to someone who is HIV positive, should they take HIV drugs in order to prevent them from getting infected, or if they've had an event, to have it after the event to try and prevent infection from happening. So this was a study in the UK, and what they use for prevention is that Truvada thing that we talked about before. So it's the tenofovir with FTC in the one pill. That's the one that can hurt the kidneys and can hurt the bones, so that's a concern if people are on this for a long period of time. And what they did is they did a study where they had MSM who were potentially at risk randomized to get PrEP or not. And what happened was those who took the prevention were 86% less likely to get infected than those who didn't. And so this trial got closed, and they said, okay, this is something that you should do. So somebody who is at high risk of getting HIV, who's not HIV infected, should consider taking this before sex. The study that Canada participated in was something called IPER-Gay. And what they were trying to do is figure out how often you have to take it. So do you have to take it every day? Do you take it in the heat of the moment? Do you take it in the heat of the moment and then after the fact? And so what they recommended is you take this in the 24 hours before you have sex, the day after you have sex, and another day later. And again, they showed that it worked. There's been all kinds of these studies out there now on prevention, taking treatment to prevent getting infected. And the bottom line is, if you take it, it works. The problem is people are people, and at the beginning they take it and then they get lazy and then they don't take it and then it doesn't work. We don't know just yet what the minimum amount you have to take in order to prevent you from getting infected, and so those are studies going on, and Dr. Tan at St. Mike's is doing a bunch of programs now in Toronto to try and understand this a little bit better and to make this available for people who want to take it. The problem for us in Canada is this drug is not licensed for this purpose in Canada. So if we're going to give it to you, we have to lie, which lots of doctors lie when we're giving things, but it makes things difficult. So we have a lot of pressure on the company to try and get the indication in Canada so that we can prescribe this to be used to prevent infection. I think the take-home messages tonight is HIV treatment works. It works very well, and it's got less toxic over time. So it's now recommended that if you have HIV, you should be on treatment. I think I've shown you lots of stuff tonight that the integrase inhibitors are really emerging as an important component of therapy. And if you're not on an integrase inhibitor, you might want to have a chat with your doctor to see if an integrase inhibitor might be an appropriate drug for you, or if you're on something that's working fine and you're doing well, to leave it alone. We're trying to look at new strategies, trying to cut down on the number of pills that people need to take. That PrEP does work if you take it, and I think what's happened with hepatitis C is incredible, and our ability to cure hepatitis C is really becoming a reality, and the hepatitis C people really learned from the HIV people about how to treat this. And so all of the research that we've done in HIV has really allowed for these hepatitis C treatments to be developed, and hepatitis B is next. And there's now a whole bunch of drugs that are going to be emerging for hepatitis B, and we're going to be able to get that virus under control as well.